Welcome today for the webinar organized by Bharat Serum and Vaccines under the Bridging Bharat campaign on the role of reproduction, immunology, and immune modulation in RPL and RIF series, which involves the why, when, and how. So today we are going to focus on the why immune modulation in RPL and RIF. So let me introduce today Dr. Mohan Raut, who is a consultant gynecologist and obstetrician. He's a partner in Dr. Raut Center for Reproductive Immunology, Women's Hospital, and a trustee for the Immune Therapy Foundation. He's been involved in active immune therapy programs, and he has contributed a chapter in immune therapy in repeated miscarriage in the book Pregnancy at Risk, Current Concept, published by Foxy. And he's currently writing a book, Immunotherapy in Repeated Miscarriage and Interposition Failure, called New Horizons, with Dr. Mugdha Raut. Welcome, Dr. Mohan, and I request you to kindly take the proceedings forward.
Please unmute, sir.
Hello. Good evening, everyone. A warm welcome to the TOG series of webinars on role of reproductive immunology and immunomodulation in recurrent pregnancy loss and repeated implantation failures. This series of webinar has been conducted with Science Integra as academic partner and with educational grant from Bharat Serum and Vaccines. This is a unique series of webinars because it is for the first time that such webinars are organized on, open webinars are organized on the subject of reproductive immunology. I extend a warm welcome to all the doctors who have registered for this webinar series and especially warmer welcome to my doctor friends who have registered from out of India. Friends, reproductive immunology is an important field in the subject of immunology. It deals with immunology of pregnancy, its role in healthy pregnancy, and in obstetric complications like recurrent pregnancy loss, recurrent implantation failures, pregnancy-induced hypertension, intrauterine growth retardation, and many more. In our practice, we come across these patients of recurrent pregnancy loss or repeated implantation failures, where in certain patients, or to the extent of almost 50% of patients, we don't find the exact underlying cause. We label them as unexplained. We are not able to help these patients, and these patients many times are left to nature. Are these patients are these patients who have the immunological problem as the underlying cause, or to be specific, alloimmune problem as the underlying cause? This problem of alloimmune rejection of pregnancy has been discussed, studied, researched for many years. But still, there are certain areas in reproductive immunology which are still considered in gray zone, especially the diagnosis and the mechanism of action of various immunomodulatory treatments. But as for any problem, if we don't take it head on, if we don't discuss it in open, we are not likely to find solution for these problems, or even we may not be aware that such solution to these problems do exist and we don't know about it. So the aim of these webinars is to throw more light on this complex subject of reproductive immunology and immunomodulation. For convenience, we have divided this topic into 4 parts, and like the first part will cover why immunomodulation, or why we should consider immunomodulation in repeated pregnancy loss and recurrent implantation failures. In the second webinar, we will discuss when we should consider immunomodulation and in which cases it is going to be useful. In the third webinar, we will discuss about how immunomodulation is done, how various immunomodulatory treatments are given or immunotherapies are given. And in the fourth webinar, the most important part is about the controversies, about the recent evidence and future of immunomodulatory treatment in recurrent pregnancy loss and repeated implantation failures. When we plan this, the second part of each webinar is a session on case discussions. When we discussed about these webinars to various doctors, we realized that there are still significant number of, or at least some doctors who are well versed with the reproductive immunology, and they had practiced in the past, or they are still practicing immunomodulatory treatments in their current practice. So we have arranged these case discussions where we have invited these experts with experience in immunology, reproductive immunology, to share their experiences. This will help us to know more about the cases which we have called as unexplained and we don't know their exact solution, to know more about how these patients were managed by these doctors, so that we can extend this to our patients and our patients will be benefited. So let us begin with the first webinar, and I would like to invite our speaker today, that is Dr. Mugdha Raut. Can we get her CV, Mr. Session? So Dr. Mugdha Raut, she is a practicing gynecologist. She is a partner in Dr. Raut's Center of Reproductive Immunology. She is editor in the Evidence-Based Women's Health Journal of Evidence-Based Women's Health Society, Egypt. She is the managing director of Dr. Raut's Women's Hospital at Mumbai. She is a member of the Education Committee of American Society of Reproductive Immunology and member of the Journal of Editorial Board of Journal of Evidence-Based Journal on Women's Health Society. He is member of American and European Society of Reproductive Immunology and of course members of MOGS, FOXI and FIGO. He has received multiple awards, Times of India Healthcare Achievers Award for 2008 for work in reproductive immunology, Prime Healthcare Award Achiever Award, Femina and Cosmopolitan Top 10 Influential Women Award, iGlobal Healthcare Achiever Award. Publications, she has written multiple papers, but currently she is writing a book on immunotherapy in repeated miscarriages and recurrent implantation failures, A New Horizon, with Springer Publication, Germany. So I welcome Dr. Mugdha to start her talk.
Good evening, everyone. Thank you, Dr. Mohan Raut, for the introduction. And I would like to thank TOG and Bharat Serum and Vaccines for giving us this opportunity to present a topic which is very close to our heart on reproductive immunology. At the outset, I would like to thank my alma mater and Seth GS Medical College, where this opportunity of reproductive immunology came to us, and from where I did my MD, MBBS and MD. This reproductive immunology project came with the help of our teacher, Dr. Usha Krishna. I need to change the slides. Yeah. I would like to thank Dr. Usha Krishna, who is considered to be the pioneer of immunotherapy in India. And she chose my husband, Dr. Mohan, and me for this project. Next slide. So today I will be talking of the impact of reproductive immunology in unexplained repeated miscarriages and recurrent implantation failures. Let us see if it is a myth or a reality. We all know the definition of repeated miscarriages. According to ASRM, it is 2 or more miscarriages, and ISHRE defines it as 3 or more miscarriages. So according to ASRM, the women affected by repeated miscarriages is 1 to 2%, or by ISHRE it is 0.5 to 1%. Next slide. The definition of RIF, we all know, but the most common one is that there are 3 or more embryo transfers or 4 embryos in women less than 40 years. Next slide. Now, whenever we get a patient with failed miscarriage or failed IUI or IVF, and when they come to us, they are very depressed. So we listen to them and we tell them that you just wait for the second miscarriage, wait for the second IVF. And why do we say so? We say so because it is based on these following statistics which have been taught to us. A risk of miscarriage in the of any first pregnancy is 11 to 13%. After one loss, it is as high as 14%. After 2 miscarriages, it triples to 30%. After 3 miscarriages, almost 33%. After 4 miscarriages, the risk of miscarriage in the subsequent pregnancy can be as high as 60%. And after 5 or more miscarriages, the chance of miscarriage in the subsequent pregnancy can go up to 50%. Next. Now, it's nothing different in IVF also. As this study was done in November 2017 by Natalie Cameron, which shows that during an IVF, 8.3% women had a miscarriage, 30% have at least one live birth, whereas 62.3% have no pregnancies at all. Next slide. So now after they come to you for the 3rd time, they say everything was normal, doctor, till now. Embryos were good, everything was fine, all our reports are fine. Then why did it fail again the 3rd time? Why did we miscarry the 3rd time? So we need to find out whether repeated miscarriages or IVF failures are 2 sides of the same coin. Next slide. Because the causes of repeated miscarriages or IVF failures are similar. As we can see in this circle, the incidence of genetic or chromosomal abnormalities in the parents of the fetus is 2 to 5%. Anatomic malformations can account for 10 to 15%. Autoimmune disorders or clotting disorders can account for 15 to 20%. Endocrine or hormonal can account for 15 to 20%. And the large orange group is about 50 to 60% are unexplained. We do not have an answer in majority of the cases, and this couple is then left to nature. The same is in the IVF. It is estimated that approximately 10% of women seeking IVF treatment will experience recurrent IVF failure. So, is there any explanation which we can offer this frustrated patient? It is not only that the patient is frustrated, as doctors, we are also frustrated because we just cannot offer any solution, and it ends that either we lose the patient because patient is going to go to another doctor, take an opinion and bound to do doctor shopping. Or one question which comes to me, that should we wait for a woman or a couple to have a pregnancy that late when parenting becomes extremely difficult and there could be a lot of medical issues for the couple. Also, some couples are just left to do some desperate attempts and they lose a lot of valuable ovarian time, which we all know, where we all know that they're near menopause and we've already lost from that. By the time they're going from one doctor to another, they have already lost a lot of valuable ovarian time. Next slide. So then why reproductive immunology? Next slide. Let's go on to the this of Sir Peter Medawar, who is a Nobel laureate and considered to be the father of reproductive immunology. He put forth one question many years back: how does a pregnant mother manage to nourish within herself for weeks and months a fetus that is an antigenically foreign body? So considering that if the fetus is an antigenically foreign body, so there must be some immune mechanism to help in a successful pregnancy and to accept a foreign body. So let's get back to the basics of the immune system. We all know that our immune system is our body's protection against any invader. It defends our body against a wide range of pathogens like bacteria, viruses, microorganisms and altered cells of our own body. And it consists of a network of tissues and organs that work together to defend the body against any attacks by foreign invaders. Yet, this powerful defense system is overcome in mammals in pregnancy where the fetus grows in the mother's body, also known as viviparity. This arrangement of viviparity does provide maximum protection against environmental hazards, but introduces a critical requirement for circumventing or bypassing immune rejection. So understanding how the maternal immune system responds to pregnancy is critical for our ability to better diagnose, understand, and treat various pregnancy complications. So what is the immune response in general? We all know that the immune system has two responses. First is a recognition of the foreign antigen and second is the response. However, the immune system also has a second arm, which is like the yang of the Chinese balance of yin and yang. The destructive forces of the immunological army are balanced by this second arm of the immune system, protecting the self as well as the fetus from altered immune responses. And this immunological equilibrium, balancing lymphocyte activation and control, is extremely important to prevent any response to self and other harmless antigens. Any disturbance in this equilibrium will lead to autoimmune or alloimmune disorders. During the last 25 years, it has become clear that a large percentage of the unexplained repeated miscarriages or implantation failures may be due to the alloimmune cause. It has also been seen that more the number of miscarriages, more is the chance of the alloimmune factor. So to understand the immunology of a successful pregnancy, let us see how the mother's body prepares herself for immune response before conception. The endometrial lining is immunologically different from other mucosal surfaces. And this is due to the extensive remodeling that occurs due to the ovarian hormones. The ovarian hormones prepare the endometrium for potential embryo implantation and pregnancy. The cytokines in the cycling uterus, estrogen induces production of pro-inflammatory cytokines like GM-CSF, TNF-alpha and interferons. Progesterone induces modulation of anti-inflammatory cytokines, that is a leukemia inhibitory factor, and suppresses the production of pro-inflammatory cytokines. This is important for endometrial receptivity and immune adaptation for possible embryo implantation and pregnancy. Chemokines, which are a subfamily of cytokines, also induce, previous slide, also induce changes in the leukocyte population in the endometrium. In the mid-proliferative phase, there is an increase in the natural killer cells and the macrophages, and in the mid-secretory phase, there is an increase in the Treg cells. Next slide. Now, the ovary also has abundant population of macrophages which play an important role in folliculogenesis and corpus luteum development. The ovum and the zona pellucida express immunogenic molecules which are foreign to a mother. And Treg cells play an important role in preventing autoimmune ovarian disease, which can lead to premature ovarian failure and infertility. Now, the seminal fluid also helps to produce immune tolerance. The semen contains foreign antigens which elicit immune response in the female. Seminal fluid antigens react with the endometrial and the cervical tissue cells to produce cytokines, leading to increase in the dendritic cells and the Treg cells. The Treg cells help in generating immune tolerance of the embryo at implantation. The immune effect of seminal fluid is due to PGE and TGF-beta in the seminal vesicles. TGF-beta leads to increase in the Treg cells. Hence, the seminal plasma promotes tolerance to paternal alloantigens at implantation. Progression to pregnancy or fetal growth parameters can be compromised when seminal plasma is not there, as seen in IUGR or PIH. So then what is the immune response in normal pregnancy? Next slide. As we all know, the fetus is a semi-allograft. The embryo and the gestational tissues express foreign antigens which are derived from different maternal and paternal chromosomes. As the fetus gets 50% of the major histocompatibility genes from a genetically non-identical father, the fetus is termed as a semi-allograft. This is the paradox of pregnancy. Because according to the transplantation theory, ideally, foreign antigens expressed by the fetoplacental unit should act as transplantational antigens to stimulate a graft, that is embryo rejection by the mother. But this does not happen in majority of pregnancies, and a pregnancy is prevented from immunological attack. Now, various theories have been put forward, like physical separation of the fetus and the immune system, attenuated antigenicity of the fetus, maternal immune suppression, Th1, Th2 hypothesis, immune adaptation, innate and adaptive immunity, and various network hype. There are many theories. But, previous slide. The current theories have shown that maternal lymphocytes are not ignorant of the embryo, but instead they are actively primed to recognize the conception antigens as indicated by the presence of activated T cells and antibodies in the blood of pregnant women, leading to immunological tolerance. Next slide. And the T regulatory cells have emerged as central players in mediating this tolerance. Next slide. Now, what are exactly the T regulatory cells? If we see the T lymphocytes, they are differentiated into the CD8 or the cytotoxic T cells and CD4 or the TH helper cells or TH helper cells. Now, TH helper cells are the ones which are important in pregnancy, and they are divided into 4 types. The TH1 cells, which produce inflammatory cytokines, which is the process is irreversible. Th2 cells produce anti-inflammatory cytokines and promote B cell development, which again is an irreversible process. Th17 cells are responsible for graft rejection. They produce pro-inflammatory cytokines and they affect the pathogen community. This process is irreversible. Treg cells are the anti-inflammatory and the immune suppressive cells. Now, there are 2 types of Treg cells. One is the natural Treg cells, which come from the thymus, and the adaptive or the inducible T cells, which are mostly important for pregnancy. They are produced in the decidua and they cause immune tolerance in response to embryo, sperm, and oocyte. In this slide, previous slide. In this slide, if you see, I have said that differentiation of Th1 and Th2 cells is irreversible, whereas the Th17 cells and Treg cells are less stable and they are interconvertible when environmental situations change, which I will explain in various pregnancy complications. Now, physiologically, a decrease in the Treg cells leads to the onset of labor. Hence, a premature fall in the T regulatory cells can lead to various pregnancy complications. Infections in pregnancy can overcome this immune tolerant environment at the local and systemic levels, which generate a high level of Th1 type of response. Now, infections in pregnancy or the defenses to pathogens have maybe a life-saving response for the mother, but they can have a devastating effect on the fetus with the pro-inflammatory shift to Th1 and Th17 responses identified as key factors for preterm labor, as we see that any infection in pregnancy can lead to preterm labor. So let us see where this immunological preparation of the embryo protection is seen. It is seen in the level of the non-pregnant uterus, which we have already seen, the developing oocyte, the fallopian tube, and the seminal fluid. Next slide. Now the concept of pre-implantation immune suppression, it occurs at different levels. At the sperm level, which we discussed, the seminal plasma, the effect of circulating hormones and cytokines released during ovulation and fertilization. Next slide. Let's see the immunology of the pre-implantation embryo. The embryo expresses cytokine receptors and it interacts with the cytokines produced in the fallopian tube and the endometrial lining before implantation. Failure of the fallopian tube to produce growth factor support or adequate immune protection can lead to unexplained infertility. And the pre-implantation embryo produces HLA-G, which acts as an immune suppressive molecule. The HLA-G is supposed to be immune suppressive. The pre-implantation embryo also produces HCG, which suppresses the cytotoxic effect of T cell recruitment into the implantation site. Again, the decidualization of the endometrium, changes in the extracellular matrix, increase in the NK cells, macrophages, dendritic cells, and Treg cells, a decrease in the Th1, Th17 cells leads to the anti-inflammatory response. The Treg cells increase the tolerogenicity of the decidua. The natural killer cells are required for vascular remodeling and placental development. Now, I've tried to summarize this in a graph, in a table, where once the embryo enters into the uterus and allorecognition is going to happen, there are two parts played by the decidua and the trophoblast. Because of allorecognition, the decidua and the peripheral blood help in the increase in the Treg cell population, causing the Th2 response, which increases the levels of interleukin 4, 10, and 13, causing a facilitation reaction, which produces blocking antibodies which protect the pregnancy. On the other hand, the trophoblast starts producing HCG, progesterone, progesterone-induced blocking factor, which in association with the Treg cells causes local immunosuppression, and this protects the pregnancy. And the exact reverse happens when there is going to be embryo rejection. When there is failure of allorecognition, the decidua and the peripheral blood decrease in the Th17 cells, causing a Th1 response with the production of tumor necrotic factor alpha, interleukin 2, and interferon gamma, causing a rejection reaction. No blocking antibodies are produced and the pregnancy does not grow. On the other hand, the trophoblast produces low beta HCG, that is low progesterone, and that is low PIBF, so there is no local immunosuppression, causing destruction of the pregnancy. Next slide. So a compromised function or a decrease in the population of Treg cells can lead to defective implantation, placental dysfunction, leading to repeated implantation failures, repeated miscarriages, or pregnancy-induced hypertension. Low levels of Treg cells in early pregnancy are predictive of a miscarriage risk. Increased number of CD16 dim and CD56 dim, CD16 bright, and a decrease in the CD56 bright and 16 dim uterine NK cells are seen in repeated miscarriages and recurrent implantation failures. And reduced HLA-G expression by the embryo can lead to PIH or repeated miscarriages. So at what levels can an immunological attack happen? It can happen at ovulation or recovery of the eggs, where the TNF-alpha acts on the ovary. It damages the DNA in the eggs by apoptosis. Spot welding occurs in the DNA so that the DNA divides poorly. This represents in the form of embryo, shows slow cellular division, fragmentation of the cells, inclusions in the cells, also causes failed IVF, implantation failure, and cause premature ovarian failure. Before implantation, the natural killer cells which are resident in the uterus and the TNF alpha again cause apoptosis of the DNA in the embryo, leading to spot welding of the DNA. Embryo grows very slowly and dies, or the embryo never attaches, or the placental tissue grows with no embryo in it. After implantation, the TNF alpha damage and the natural killer cells can cause decidual necrosis. They cause subchorionic hemorrhage, placental death, yolk sac damage, a slow heartbeat in the early stages of pregnancy, irregular gestational sac, and too little amniotic fluid. Now, whenever we are doing immunomodulation in the form of lymphocyte immunization therapy or immunoglobulins or various other immunomodulatory treatment, our aim is to convert, according to the blue arrows, is we try to convert the help in the conversion of the dendritic cells to the Treg cells and a shift from the Th17 cells to the Treg cells, which causes immune tolerance. Next slide. Now, there is ample evidence that shifts in the level of subsets of peripheral and endometrial NK cells, changes in the functional NK cytotoxicity, alterations in the cytokine ratios of the T helper cells, and the presence of autoimmunity to both organ-specific or non-specific antigens occur both systemically and locally in recurrent pregnancy loss. So from this presentation so far, it is pretty clear that there are far too many immunological events occurring throughout pregnancy, and it is impossible to turn a blind eye to them. If we do not take cognizance of the immune mechanisms during normal pregnancy, we will fail to understand the abnormalities in the immune system leading to recurrent implantation failure and repeated pregnancy loss and other obstetric problems. So friends, it is time to see recurrent pregnancy loss in the light of immunology. I would like to thank you all with this slide where we try to go into the pro-tolerance or anti-inflammatory response. However, I would like to end my presentation again with Sir Peter Medawur's sentence, is that the purpose of science is to change belief. And if you believe that infertility, implantation failures, and recurrent miscarriages, and further, oligohydramnios, PIH, and prematurity are God's will, which is not treatable scientifically, you will never try to find an effective treatment. Thank you, friends.
Hello, Mugdha. I have a question.
Hello. 1 minute.
Yeah.
Dr. Mugdha?
Yeah.
Thank you, Mugdha, for this lovely, very scientific presentation. And
Thank you, madam.
I have just one small question. I was just going through some papers, and I did come across this seminal plasma suppository.
Yes.
You know, and since you were mentioning about seminal plasma and its immunomodulatory effects, I was wondering, you know, I had never heard of it. And I don't know where it is being used, or it was just, you know, used as a, you know, as a research in some institutions.
Right.
I
Yes,
just want
Dr.
to know if you all have
Madhu.
heard.
Yeah. Yes, Dr. Madhu, I think seminal plasma does have a role, and there are studies which have shown that the couple is asked to keep relations even after embryo transfer natural
So
relation.
we normally tell them not to, you know, after the
certain centers are asking them to keep relations after IVF.
Okay. So this is the reason behind that.
Yeah.
Okay. Thank you.
So thank you, Dr. Mugdha. for an excellent overview of immune system, immunology of pregnancy, and its importance in various obstetric complications like recurrent pregnancy loss, recurrent implantation failure, IUGR, and even pregnancy-induced hypertension. Actually, listening to this elaborate presentation reminded me of one dialogue from Munna Bhai MBBS. When Munna Bhai tells circuit, जब हड्डी तोड़ते हैं तो मालूम पता नहीं रहता है शरीर में 206 टाइप की हड्डी रहती है. Something feeling something like that has come that when we treat patients who are pregnant, we help them to get a nice baby. We don't know that there is an elaborate philharmonic orchestra of immune system is going on in the background with different type of cells and cytokines and chemokines to help us achieve the normal pregnancy. So thank you again. We move to the next part of the webinar, and that is the case discussion. We have invited experts in the field to, as I mentioned, to share their experiences about treating patients who are considered to be difficult to treat or unexplained, and how they have achieved the success in their practice using their knowledge, experience in the field of obstetrics and also reproductive immunology. So I think we have 4 guests with us. Dr. Urvashi Sehgal from Delhi. So I think I will introduce them before, so that once we start the discussion, then we can go ahead with question answers after that. The first one is Dr. Urvashi Sehgal. She is a senior consultant in gynecology and obstetrics for last 20 years, practicing in Delhi, director of Phoenix Hospital and visiting consultant at La Femme Apollo Hospital and Rosewalk Hospital. She has a lot of achievements and awards to her credit. She is a recipient of President's Gold Medal MBBS in MBBS, Distinguished Service Awards for Delhi Medical Association, Distinguished Service Awards from Indian Medical Association, and pioneer of water birthing technique in India. He is a member of various societies, including Indian Society for Study of Reproduction and Fertility, life member of Association of Obstetrics and Gynecologists of Delhi, life member of Federation of FOXI, that is, and life member of Indian Menopause Society of India. So I think we will start with the second one. I think Mr. Session. The second doctor is Dr. Renu Makwana. She is an expert obstetrician and gynecologist from Jodhpur. She has a diploma in, she is a fetal medicine specialist, diploma in pelvic surgery from Kiel University, Germany, executive member of ISPAT, founder chapter secretary ISAR Rajasthan, founder secretary IMS Jodhpur, vice president FOXI Jodhpur, trained more than 250 gynecologists in ART, actively involved in various academic activities since 1995, and she is director of Vasundhara Hospital Limited, Jodhpur in Jaipur. The next is Dr. Madhu Gulati from Gorakhpur. She is founder member of FOXI Gorakhpur branch, life member of Indian Fertility Society, life member of ISAR, North Zone coordinator for International Academic Exchange Program FOXI 2004, joint secretary of UP chapter of ISAR, president FOXI 2015-16 Gorakhpur branch, founder member and vice president of IMS Gorakhpur, organizing secretary of UP COG in 2016, organized infertility workshop in UP COG in 2016, and she is instrumental in the establishment of Purvanchal Institute of Science, Gorakhpur, and is a senior vice president of the institute. And the last, the fourth participant guest is Dr. Sunita Chandra from Lucknow. She is the chairperson and director of Rajendra Nagar Hospital, co-editor. Can you remove this? Co-editor of the manual Improving Surgical Skills in Obstetrics in 2020, secretary UP chapter of IFS for 2022, founder joint secretary UP chapter of IFS. I think that she was busy with the meeting just now, some time back. Organizing committee member of AICOG 2020, presently secretary medical legal committee of LOGS, and trained with distinguished experts like Dr. B.N. Chakravarti, Kolkata, and Dr. Rajan Kottayam. So I think we will start with our case presentations. We will start with Dr. Urvashi Sehgal, and these our guest doctors have shared cases from their own practice. These are the real patients whom they have treated, and they have achieved success. So I will start with Dr. Urvashi Sehgal, and this is our first case, a case of primary infertility with endometriosis. Patient P, 35-year-old, with history of infertility for 10 years, history of grade 4 endometriosis, for which laparotomy with adhesive lysis and excision of bilateral endometriotic cyst was done 5 years back. She was unable to conceive. She underwent multiple failed IUI. Multiple IUIs were failed, and one failed IVF. Now, what should be done, or what Dr. Urvashi has done for this patient? Over to Dr. Urvashi.
Thank you, Dr. Rao. Thank you for making me a part of this very relevant and important webinar on reproductive immunology. So this patient came to me 20 years ago. And at that time, she had been married for 15 years and had been trying for 10 years. And in the course of her investigation, she was found to have very severe endometriosis, and then she underwent a laparotomy like it's shown in the slide. And after that, she underwent multiple IUIs which failed. Then she underwent an IVF which also failed. So when she came to me, she was very depressed. And of course, she had undergone all kinds of investigations, so I didn't have to investigate her much more. She had gone through her anatomic, endocrinologic, and infection, and even the chromosomes and everything, the whole works.
Everything was normal, madam. Right?
Everything was normal. And that's when then I discussed the concept of immunological dysfunction, which may be leading to endometriosis and infertility. And I asked her to read about it also. Meantime, I told her to get her thrombophilia screening done, her anticardiolipin, her lupus anticoagulant, beta-2 glycoprotein, and those were normal as well. So then I discussed about the reproductive immunophenotype. That is quite an expensive test, but she was in a position to afford it, so she went ahead and got it done. And
can you elaborate on that, madam, before we go to the treatment part? Means why did you think of immunological factor, and which investigations did you do?
So I thought of the immunological factor because everything else was normal. And since everything else was normal and she had this problem of endometriosis, and she was not able to conceive even after she had gone through all the clearing of her endometriosis. So what remained in my mind was that maybe her immune system is what is dysfunctional. And endometriosis can also arise because it is known to have immunological etiology as well. So the tests that were available at that time was NK cells and TNF alpha. These were the two tests that I knew of, and these were the ones that were available. And we did those, and those were found to be abnormally high. So now came what was the treatment for it? And then again, I asked her that she should do her research on immunotherapy because, since at that time it wasn't widely accepted. Even now, a lot of people view it with skepticism, but at that time it wasn't. So I want the patient to do her own reading and then tell me what she wants. And For her, this was her last attempt. So she said that after reading up about it and discussing it with some people, she decided to go for it. And she was started on lit, and then after 3 lits every 2 weeks, surprisingly, and it seemed like a miracle at that time, she tested positive for her pregnancy. And then her levels kept increasing normally, and she successfully carried that pregnancy to term. And surprisingly, she got, after her first baby, she got pregnant the second time very soon without any lit therapy or any assistance, and had her second baby. And after she had completed her family, she continued to get pregnant, which unfortunately those pregnancies had to be terminated. But this is her story, and my first patient that I treated with immunotherapy.
Yeah, that is interesting. I think, would you like any of the panelists to comment on this about endometriosis and infertility, and whether anyone had a similar experience, or because endometriosis is so common, whether any of the immunological or immunomodulatory treatment anyone has used? Because it is known that endometriosis is a condition which is, if you see from immunological point of view, with predominant Th1 type of response. There are increased Th1 type of cytokines which are seen, like TNF-alpha. They are invariably associated with very high level of TNF-alpha, and therefore immunomodulatory treatment does help in patients who have endometriosis. I think we'll go to the second case.
Just like to comment about endometriosis. I would just like to comment. Can I comment?
Yeah, please. That's what
So actually, I have a similar patient of endometriosis. She was being operated for big chocolate cyst twice, and she did not conceive for about 7 years. And she kept on developing chocolate cyst. Her AMH level was good. She never went for IVF, but she was not conceiving, and she was a family member. So I was also very worried how to make her conceive. Pregnancy was really very, very important for her. Then we went for all the tests. Everything was normal, but her TNF-alpha was high. So what I did was, I just started her on prednisolone, and I gave her Bharglob every 21 days. And I just kept on seeing her about her ovulation status and all. And after 3 months, she conceived. Then I just kept her on steroid, prednisolone 10 milligram OD for 15 days, and then I tapered it down, and she delivered a baby. Then again for the second pregnancy, she did not conceive for 8-9 years again. And then again, her TNF-alpha was high, her cyst was again very, very big. I did a surgery. I'm just quoting this patient because this patient for 2 pregnancies, she had problem. But later on, she kept on conceiving, and finally I had to ligate her. But those were normal conception without any treatment. And the worst part was that she developed cardiomyopathy in her second pregnancy. And that was again because of immunological aspect of this endometriosis. So she could never continue the third pregnancy because of that cardiomyopathy. So endometriosis is really, really important if we think about immunological status, if we think about immunology about endometriosis.
Definitely, Dr. Sunita, because the role, what you mentioned of Bharglob is a very important adjuvant in these patients because of its anti-inflammatory action.
Yeah.
And it has been an immunomodulatory action, and it has been an important adjuvant along with other treatment in such patients where there is high level of Th1 cells or TNF-alpha.
Yeah, she had so much, like she developed cardiomyopathy in second pregnancy, and I just delivered her, and our cardiologist said that she cannot go for next pregnancy now. So that was the status because of endometriosis. Only her whole immunological dysfunction was there in her body.
Oh, great. I think we'll go to a second case, Dr. Urvashi.
Yes, sure.
So this is a patient, 38-year-old, a white American, married to Indian Sikh, trying to conceive. She used to get multiple repeated urine pregnancy tests positive even before missing her date, and so they turned out to be biochemical pregnancies because each time the beta HCG used to be close to 60 and 80, and so this confirmed that she had multiple biochemical or chemical pregnancies. So how did you go ahead, madam, with this patient?
So this case came to me about 18 years ago. And just like it's mentioned, her urine pregnancy test would come positive every month. And I thought this must be a false positive. How can someone have a pregnancy test positive every month just before the period, and then she starts bleeding and then it becomes negative. So I said, you should do a blood test. And when she did a blood test, I mean, sure enough, it was between 60 and 80. And then I realized that every month she was having biochemical pregnancies and chemical abortions. So then she had no test done for her infertility. So we did a full workup, which included her, anatomic. So at that time, her HSG was done, and then her thyroid, her TPO, her prolactin, and her diabetes screening. Her chromosome as well as her husband's chromosome, his semen analysis and fragmentation, morphology, all that was done. And then, of course, the thrombophilia screen. All these were normal, including the thrombophilia screen. So the only thing that remained then was the immunological aspect. And so before I asked her to do the reproductive immunophenotype, I told her about what I was thinking and how the body's immune system may be not accepting the pregnancy, may be rejecting the pregnancy, and that she should again go read about it, and then if she would like to do the reproductive immunophenotype. So she said she would, and we did NK cells and TNF alpha, which were abnormally high. When it came to the treatment, again, in her case, just like the previous case, I asked her to do all her research. She was a very intelligent lady. And in fact, I even gave her the contact number of the previous patient and said, if you want to discuss her treatment and all that, she can go ahead. So she did that, and then she reverted back to me and said she wanted to go ahead with LIT. And after 3 months of initiating LIT, her tests were done again, the NK cells and the TNF, and those levels were normal, and then she was asked to start planning. And again, of course, she used to get pregnant very easily. Her pregnancy test was positive, her beta HCG was positive, it kept doubling, and all her ultrasounds were fine. She had a good pregnancy and gave birth to a normal, full-term, healthy baby. So
that's great. Any of the panelists would like to share their views or about biochemical pregnancies? Because there was a debate some time back whether biochemical pregnancy should be considered to be counted into the pregnancy loss or not. But now it is proved beyond doubt. Studies really conducted through ESHRE committees have the early pregnancy loss committee of ESHRE have confirmed that as the number of biochemical pregnancy increases, the obstetric outcome worsens, as it happens with a documented pregnancy loss. So therefore, biochemical pregnancies are to be treated as like a documented miscarriage in predicting the obstetric outcome of subsequent pregnancy. So that is one part. And here, why do you, madam, think about the immune problem, the TNF alpha and
NK cells are high?
Sorry, I can't hear you.
Dr. Mugdha, if you would like to take this one.
Yeah, the question was why did you think because the TNF alpha and the NK cells were abnormally high, that was the reason you thought of an immunological problem?
Yes, and also, of course, when you ruled out everything, the only thing that remained was this, and this was abnormal.
So you went for LIT.
Yes, right.
Hello?
Yeah.
Sorry, I think there was some
giving a LIT treatment every 15 days, or what was the schedule?
Well, this was every 15 days. And when she got pregnant and the levels came down, it was reduced. And then
Even after pregnancy, you continued with LIT?
Yes, it was continued even now. Although Dr. Rao tells me that nowadays they give only one, if I'm correct. And they do
the protocol that we use only one pre-pregnancy, but if the patient comes pregnant, then we do give in pregnancy also. So
do you monitor it with levels, or how do you do it?
We do the test before, like I said, of course we'll discuss it in the second webinar. We do the lymphocyte cross-match and other tests, NK cells and TNF alpha, and then go ahead. So I think we'll discuss that at that time.
Okay.
So we'll come to the next case, and that is a secondary recurrent pregnancy loss. I think with 33-year-old patient with 7 gravida with 5 first trimester losses with 1 full-term delivery. So a secondary recurrent pregnancy loss. So madam, how did you go about?
So this patient belonged to a slightly poorer socioeconomic status. So of course we did the basic workup, karyotyping, and some partly thrombophilia screening also. Her HSG and those anatomic and hormonal factors we ruled out. Now, she was not able to afford the reproductive immunophenotype investigations because those cost about a little, which was a little steep for her. And therefore, since this was the only thing left in her case, I just discussed with the couple that there is this concept that the uterus may be rejecting, her body may be rejecting the pregnancy, and one can try immunotherapy and see whether it would help. So would they be keen to start? And so again, they were desperate and they wanted to start. Now in her case, LIT would have been expensive for her. So the cheapest option that I could think of was HCQS. And it is known to be an immune modulator, and I'd read some studies that it has shown definite benefit in recurrent pregnancy loss due to immune causes. So we started, we had nothing to lose, so we started HCQS and added on injection Bharglobe as well. So 2 months after initiating the therapy, she was asked to plan without doing any further tests. And she got pregnant, and then the viability scan was normal for the first time after the previous 5 miscarriages. And then the 12-week scan, the fetal parameters were normal, but there was a very high uterine artery impedance. So for that, we started low-dose aspirin and also low molecular weight heparin. The pregnancy went quite smooth after that. And of course, when this was written, she was 34 weeks, and now she's 35 and she's gone into labor. And I may be called any minute to attend her delivery now.
Great.
Oh, that's a great news. I think, madam, HCQS, can you elaborate a little more on HCQS? Means why did you think so?
One question from my side also regarding HCQ. Yes. Yeah, first and foremost, HCQ, of course, it's the Ramban Ajkal na, for all the latest COVID problems also. But HCQ, would you give it for 3 months or 6 months? How long would you give it prior to the patient being asked to plan? And do you continue it in pregnancy? And do you get an HCG done? Or what is the dose, 200 BD or 400 BD?
I had read,
because it's a very cheap and simple solution.
Exactly. So I had actually attended a conference, and there was somebody from, I think either it was Sweden, I forget, and she spoke about HCQS, and I thought, why not try this? And it is an immunomodulator, and it is used in SLE, and so She took it for 2 months at a dose of 200 milligrams twice a day.
Okay.
And then 2 months after that, I asked her to plan.
Okay.
And it seemed to work because
if I may
That's
add
very,
to
that's
this,
very nice.
but I
That's very
can add-
continued it through pregnancy. Yes, I continued it.
yeah, if I may add to this discussion on HCQS, we have been using HCQS very regularly in patients who have high TNF
Okay.
alpha, and they are used. We start
Okay.
even before conception, continue throughout pregnancy till 36 weeks of pregnancy, 400 milligram daily. And these patients, especially even those who have late pregnancy losses or complications, HCQS helps to prevent it. And we have been using regularly in these patients after even after giving lymphocyte immunization therapy to maintain the effect throughout pregnancy. HCQS is continued, especially with high TNF alpha, and it is very safe.
So you are using it a dose of 400 or 200?
400.
400 at bedtime.
My patient took 100 twice a day. I thought it's easier to tolerate a smaller dose twice a day. So,
Good.
And Bharglob also we continue till 36 weeks of pregnancy, every 21 days, or depending on the case, even every 15 days also.
15 days
Right,
also. We
right.
give it 15 days.
Good, good. This is
Good,
something
so
very
I think-
nice.
So I think with this, we will go to our second speaker.
So Raut, may we request you to share the slides, please?
Yeah, sharing that. Okay. Okay. So we'll go to our second speaker, Dr. Renu, and I think we'll start with our first case, a case of recurrent IVF failures. 28-year-old female with male factor of infertility underwent 3 IVF cycles, good quality embryos. In spite of that, there were failures. So I think we'll ask Dr. Renu how she went ahead with this patient. I think all investigations otherwise were normal.
Yeah. Hello, good evening, and hi to everyone. And
Hello, ma'am.
so this was a young female, and she underwent IVF for male factor infertility. Everything was normal. There was no PCOS. Hysteroscopically, cavity was normal. Everything was perfect. We used to say after pick up and embryo transfer, yes, this cycle will be good. But every time failure. So then we thought about the causes for RIF. And we underwent hysteroscopy because the 4 or 5 years back, that was so much told about the hysteroscopy and coring of the cavity, everything was there. Then I discussed about the immunological causes for implantation failure. And at that time, lead therapy, there was so negative in the reports that lead therapy should not be done and like this. So I got a TNF alpha test. It was high. I ruled out genital tuberculosis, did a hysteroscopy, hereditary thrombophilia test. Everything was normal. Then for immunization, it can be active immunization by lead therapy or passive immunization by IVIG. And IVIG was too costly, too difficult to administer. So we chose for Bharglob injection. And I started Bharglob preconceptually. After 2 injections, again IVF was tried, and then the patient conceived in the 4th cycle, and this Bharglob was continued during pregnancy. So, but I continued till 20 weeks of pregnancy, and patient delivered normally in this conception, and that was great relief. So with TNF alpha, I decided to give her Bharglobe.
That's great, madam. Have you encountered any side effects of Bharglobe injections? We have used them regularly, so
No.
so
It
it's
was
a
Yeah, I think Bharglobe is very safe compared to IVIG.
yeah.
And more economical also we feel for the patients. Yeah.
Can anybody
If you go for passive immunization, if you read about passive
allergic to
immunization,
it or sensitive to it? I mean, can people have allergic reactions to this intramuscular injection?
Never seen it till date.
Never
I've
seen.
been using a Bharglobe for I think donkey's years. I'm so happy that they've reduced the price of it also. For our where I work, low resource setting, it is quite helpful. I haven't yet had an allergic reaction to it.
okay, great. So I think Bharglobe did the trick. We'll come to the second case, which is a case of recurrent pregnancy loss. 31-year-old patient, recurrent pregnancy loss. I think there were 2 miscarriages, and she came during third pregnancy to Dr. Renu.
yeah. So this was a case having every time 7 to 8 weeks heartbeat comes and patients come with absent cardiac activity in the next same week. And I got her hereditary or acquired thrombophiliae testing done. Everything was there, and I supplemented with low dose aspirin, aspirin with 150 milligram per day along with Lonopin. That is LMWH. In the third pregnancy, in spite of that, no heartbeat in the 8th week. Otherwise normal. And karyotyping, microarray, everything was normal. So now what to do? And her AMH was normal, BMI was normal, she was euthyroid, no diabetes, every possible test was done. And then in third pregnancy, it was so frustrating that she comes with the same gestational age and missed abortion. So in next pregnancy, I gave her Bharglobe preconceptionally, along with folic acid and aspirin preconceptionally. And then she conceived. As soon as pregnancy is confirmed, I started LMWH, aspirin 150, and then now she delivered full term healthy baby with Bharglobe till during pregnancy.
So I think again this case indicates that if all other factors are normal and even the genetic testing of POC was normal, indicating that this case was so-called unexplained miscarriage, again had an immunological factor underlying as an underlying fact cause causing the miscarriages, and immunomodulation, passive immunomodulation in this case using immunoglobulins has helped, along with, of course, low molecular weight heparin and aspirin. Right? Anything
these days, GCSF factor, GCSF has also been used. Filicrastin and things have also been used in multiple pregnancies. They also work on the same principle of immunomodulators. But there are times when, in spite of everything, you still land up with a miscarriage. And then you think now you should go up higher, refer the patient to a higher center, to Delhi or Mumbai. And, for the other treatments are not available here locally.
In one patient where the uterine PI was high, and I prescribed that LMWH to the patient along with aspirin. Patient refused for daily injection, and because of cost, because of invasive thing, then I switched over to HCQS. It also gives the same results, and pregnancy continued till term. So this is also a good option, as narrated by Dr. Urvashi. So though it cannot replace LMWH, but at times we can use HCQS as immunomodulator as well.
Right. I think HCQS does play an important role, and which we have seen as an adjuvant along with other immunomodulatory agents. Yes. So great. I think both these patients were helped by use of immunoglobulin. We go to our third speaker, that is Dr. Madhu. So, sorry. So we come to the first case of Dr. Madhu Gulati. And madam, this is a 23-year-old patient married since 5 years with history of two full-term pregnancies, I think almost full-term. One expired after birth and the other expired immediately after birth, 3 years and 1 year back. And there were two miscarriages, one of 3 months and 2 months. And she has now currently come to you with 2 months of pregnancy. So how do you go about, madam?
This patient came to me on the 27th, and I got a call from you all on the 26th, I think, that we would, you all wanted me to be a part of this esteemed program.
Great.
In the morning only this patient came to me, and I thought, why not, include her in this program, because this is what I'm going to, follow her up and deal with her. And the other panelists will also help me in this case. And like you said, Munna Bhai, I will also quote Amitabh Bachchan. I am like Amitabh Bachchan, and this lady is on the hot seat from a low resort setting, and I have to take her up to winning that 1 crore prize money. है कि नहीं? And we have to take it तीनों पढ़ाओ, पहला पढ़ाओ, दूसरा पढ़ाओ और तीसरा पढ़ाओ. If you ever watched KBC, the first 3 months, the 3 to 6 months, and the last trimester, because she's had 2 abortions, she's already had 2 full-term births. They were both, the first one was at a PHC, the second one was at a small private hospital also in the suburbs. And now she has come to me at 2 months amenorrhea, low resource setting, and now what?
So the first 2 pregnancies were full term. Is that
2 full term.
And normal deliveries?
Normal deliveries at the PHCs. One at the PHC and one at a small hospital. And here, patients will wait till the end. When the labor starts, then they will go, or they won't. She has not been investigated at all. She's just come to me this time with the pregnancy test, क्योंकि अब शायद awareness हो गया कि हाँ, she is positive. Now she has come at 2 months amenorrhea with pregnancy. And how do I help her now? Apart from being a poor lady who stays in the interiors, I wrote the whole battery of tests for her. But what she just put her hands up. She said, I can't afford all this, and madam, humko to time lagega. Even when I told her you will be needing an NT scan and a double marker in a few weeks' time, it was, hum to itna paisa nahi kharch sakte hain. So I had actually no option to just do her, USG and a fetal well-being, whether she has a live fetus at the moment. Put her on Dufiston, which is also another immunomodulator, folic acid and Bhaglob. That was the cheapest and the best I could do for her at this time.
Well, ideally, what would you like to do, madam, in this case? What?
See, those 2 abortions of 2 and 3 months, there could be a very lot of reasons. It could be because of I'd like to do a routine test, all the hemoglobin profile, thyroid, her karyotyping, her
diabetes.
And diabetes, GTT. Yeah. And I think it's there in the next slide, her GTT, and then her NT scan, and even at this antiphospholipid panel, And here we have a lot of tuberculosis also, and tuberculosis is also important factor of early miscarriages, which I have seen in my practice. And so I would like to do all that, and then maybe when she comes into her mid trimester, then her level 2 scan, and then rule out any uterine blood flow resistance, and if she needs, put her on. And in fact, I think I added a low her 75 milligram of aspirin right now only, and that is all she could, do at the moment. But of course, she needs to be really followed up on each and every visit of hers, and taken up to term and advise an institutional delivery. If she cannot afford a private setup, she should go to the medical college and have an institutional delivery.
Institutional delivery, that is much more required, because the cause may be something inborn errors of metabolism or parental asphyxia, intrapartum asphyxia, that might be contributing to loss of full term.
Yeah, the full term cases are probably because of that. Because something went wrong during the labor procedure and it was not taken care of. But then, they are also very nutritionally poor, and especially in this corona times with the family being out of work and things, we have to see a lot of things, in a low resource setting. So you can't advise her too many tests, can't.
Right, but you still have started her on Bharglobe, I think so.
but सस्ता हो गया ना, 1400 से 800-900 का हो गया, तो कुछ तो. Plus I gave her folic acid and aspirin samples.
Madam, what about HCQS?
I was thinking the same.
I hadn't heard of it earlier, 2 days ago. It was only when I started reading about all this in the last 2 days that I heard about HCQS. Now next visit I'm going to put her on it, and I will personally inform both of you about it, or our entire team about it.
Sure.
I actually hadn't heard about it.
Definitely she will do well under your care. I think we will go to the second case, and that is also similar. I think late pregnancy losses. Right.
She came 2 days ago. She's married to a guy who works in a shipping line. Can you imagine? And she's a well-educated lady. But unfortunately, belonging to this part of the country, husband is abroad. When he comes, she gets pregnant and he goes off. The money sent is used for the other, it's a very pathetic situation. Money sent is used for the other work in the house or for the other members. She underwent a normal delivery कि सब लोग अब बच्चा तो घर ही पे सबका पैदा होता है और अस्पताल जाने की क्या जरूरत है. First time she went into labor in the 8th month. When the guy gave up, she was sent to the nearest CHC. She underwent an LSCS there. Second time,
right?
You saying
go
something?
Ahead.
Second time again, after 2 years, she delivered another child, 9 months. Went to the hospital with an absent fetal movements. Went to a private setup, was again operated there. उसके बाद husband आया, हल्ला गुल्ला मचाया, बहुत हुआ. Then she was taken to a setup, and she underwent a lot of tests there. Would you change the slide, please? Yeah, so all her tests were there, done there. APLA was normal, karyotype normal. PCR was done, which was positive. She was taking ATT, and sorry, ये शायद गलत type. What? Achha, it has to be taken till August 10th.
Hello.
And her anti-TPO was raised. So she was put on low because the TSH was only 4. She was put on Thyrox 12.5. Now mother-in-law brings her to me कि जिस डॉक्टर पास हम पहले गए थे उन्होंने बहुत महंगी महंगी जांचें कराई, बहुत महंगी महंगी दवाइयां दी, अब हम आपके पास आए हैं और अब इसका पति 2 महीने बाद आने वाला है और वो काम छोड़ के अपनी जॉब छोड़ के आ रहा है कि अब हम इसको 9 महीने नहीं छोड़ के जाएंगे, या till she delivers and till she conceives and she delivers. So I said this is the best thing that could happen, because you won't believe it, so many of us sterility treated patients whose husbands are working in the Gulf or Far East or somewhere else, they conceive and leave it on their house people, and they take it to 9 months, they will come to you, but last moment, in spite of your repeated request to go to a proper center or to come to me or go to an institution, they will go here and there and then land up with mishaps. So
just one question. Question means to all Dr. Madhu and also to other panelists, means have you come across patients who have late pregnancy losses where otherwise everything is normal? It's not related to otherwise related to a delivery or birth asphyxia, but there is no documented cause, and there can be an underlying immunological factor in such cases.
Actually,
just I think around 15 days back, I had a girl. I treated her for infertility. After 5 years of marriage, she conceived, and she was doing very well. She was under my observation since beginning because she was a treated patient, and they were so keen for pregnancy, and they are very close to me. And this girl, she came around 34 weeks. She came. She said, "Auntie, I'm not having fetal movements." I saw her. I did her NST. Her NST was very good. Then I said, "Okay," and I did her Doppler studies. Everything was okay. It was in the evening around 7 p.m. So she said, "Auntie, can I go home?" I said, "No, you stay in the hospital because I want to monitor your fetal hearts overnight." She said, "Auntie, I'll go home and I'll see if I don't have movements, I'll come back." She did not came back. She did not come back in the night. And morning she came to me that, "Auntie, I'm not feeling movement at all since morning, and at night I slept." I said, "Why did you come?" She said, "Auntie, I slept after having food and I did not come to you." And when I saw, I could not find her fetal heart sound. And then I got her ultrasound done from one place, two place, second place. It was an IUD. So till today, I'm thinking what went wrong. She was a non-hypertensive, non-diabetic. Everything was going very normal. Her double marker was good. Her level 2 sonography was good. She was following all the instructions very religiously. So these sudden IUDs are
very difficult to predict.
Very known.
Actually, in these two patients, I have no records whether she was hypertensive, whether she had gestational diabetes or nothing. She was
yes,
at
Dr.
the
Renu,
local
you want to?
Yeah. Even in patients, those who are normotensive, euthyroid, no diabetes, late IUGR is something which contributes to bad obstetric outcome. And in these patients, we get everything normal.
Yeah.
Even umbilical, we do screening umbilical artery, that is also normal. The problem is with the growth. So we should do trendy graph.
Growth charting graphs.
If there is
growth is normal, there was no intrauterine fetal growth retardation, her weight gain was normal. I mean, she was.
Did she have pregnancy cholestasis? Because pregnancy cholestasis sometimes has unexplained IUDs.
No, I know. Intrahepatic cholestasis in pregnancy is very bad. These are one of the important causes of IUDs.
Was a fetal autopsy done for this?
No, that is what. It was not done. They were not agreeing. Here, actually, in Lucknow, I mean, not even 1% patients allow you to go for.
Actually, these
because CTG will not tell you about many things in late age.
I know, but even Doppler studies was normal at that time.
Yeah.
So these late pregnancy losses many times
Dr. God is also
can also have an immunological factor. Do you think?
Yes.
There is some.
I feel so, because I'll go for these tests in the next before going for next pregnancy. I'll
Yes,
definitely
Dr.
go for
Mugdha.
all these tests.
In fact, I would like to share that we've had 2 patients who had come to us with similar history of late pregnancy losses. One repeatedly in 6 months and one repeatedly at 34, 35 weeks. So one had lost about 4 pregnancies at 6 months and the other couple had lost 3 pregnancies. We did the HLA cross match, we did the immune profile, and all these couples, everything else was normal. They were already investigated by different doctors elsewhere, and everything else was normal. So we did the therapy. We investigated them. In one patient, the TNF alpha was also very high. So we told them about the therapy. They underwent the therapy. And both of them, one delivered a baby girl and one a baby boy at the end of full term deliveries, both.
So you did the immune therapy in pregnancy. When they came to you, they were pregnant?
No, they came pre-pregnancy.
Pre-pregnancy.
Yeah,
Okay.
so we did the immune therapy and then they both conceived naturally. No help was required. They conceived naturally and they both went to full term.
Because
Of course,
we have
Dr.
seen
Raut
in-
will discuss about all other after immune therapy. We also put them on ecosprin and low molecular weight heparin, ecosprin 150, and the patient with raised TNF alpha was put on HCQS also.
So what do you
basically-
advise for this patient? A routine, proper, good antenatal care or some specific tests?
Yeah, first is we do these tests, we do the LIT therapy, and yes,
No.
and good. Then
I'm talking about this particular patient, late pregnancy.
late pregnancy loss, na.
This particular patient of mine. Now, what do you advise for her? Husband is coming back after 2 months.
So I think if everything else has been already done, and I think it's only if you can do one simple test of either HLA cross match and TNF alpha.
Okay.
And then ask them to do immunotherapy. First do lymphocyte immunization therapy and then plan the pregnancy.
Okay. What
Because
I
these
have
patients-
told her, this patient, because her PCR was positive, it's been 2 years now, she may have a blocked tube or some tubal factor. We see a lot of that here.
Yeah.
So I have advised her to get a sonosalpingography done day 7, day 8. And I have put her on folic acid, I've put her on antioxidants, and I gave her a shot of Bahaglo because the husband is going to come. So I said, let me do a little bit of immune therapy before he comes, and we'll get him investigated thoroughly and talk to the couple because this time he plans to stay here.
Right.
So
Great. I think so. I think even late pregnancy losses can have alloimmune factor as an underlying
and I
cause.
will talk to them and get these 2 tests done, and surely would follow up with all of you all what happened to these 2 patients.
Because we know about APLA syndrome where patients have late pregnancy losses because of the vascular complications. And it has been known that even with alloimmune problem with high Th1 cytokines, there is a condition known as cytokine-induced vascular amputation. So the blood flow gets reduced and cut off, and that can cause sudden miscarriages or pregnancy losses in late pregnancy. Okay, so I think we will go to our next speaker. That's the last one, Dr. Sunita Chandra. 1 minute. So, madam, this is your case of recurrent implantation failures. A 46-year-old female married since 20 years, history of primary infertility, 3 failed IVF cycles or donor cycles, all fresh cycles, no FETs. And how did you tackle, madam? Dr. Sunita?
Thank you. Thank you, Dr. Mohan, for giving me this opportunity. Thank you so much. And I must congratulate for a wonderful panel, wonderful talk and wonderful panel, something very different. So this patient, I did all the routine tests, TSH, prolactin, her CBC, her blood sugar, her APLA, everything was negative. Everything was good. Even her TNF alpha was normal. I do TNF alpha on all recurrent implantation failure. Here at our place, NK cells testing is not very easy, but TNF alpha is easier to get it done. So I got it done. That was also normal. Then I did her TVS and her endometrium was hazy. Ovaries were normal. There was hardly any follicle in the ovaries, which I was not even expecting. And there was a small free fluid in pouch of Integra. And as Dr. Madhu said, as at our place, tuberculosis is really very, very common. And if it is tubercular endometritis, I know that she is not going to conceive or she is not going to carry this pregnancy. So I did her hysteroscopy and I could see not tubercular endometritis, but chronic endometritis patches were there. And I did little cavity correction. And I started on Bharglobe right at the same time. I started treatment for chronic endometritis. I gave her 2 months chronic endometritis treatment and started on Bharglobe every 21st day. I always give every 21st day. I never give 15th on every 15 day. And I was following her for her endometrium. And when her endometrium became good, triple layered, nice, bright endometrium, I did her IVF, of course, with donor oocytes. She conceived in the same cycle. Her beta HCG was positive. She continued pregnancy and I continued Bharglobe till 36 weeks of pregnancy. Then I stopped and she delivered. So what I just wanted to share here is that chronic endometritis also causes increase in TNF alpha and NK cells. And it is bad. It is really immunotoxic. It is not good for the patient for conception because then your endometrium and embryo talk is not there. That synchrony is not there. And that is why there are failures, there are implantation failures. So, I don't know, it was the treatment of chronic endometritis or it was the Bharglobe which worked, but she had a healthy baby at 36 weeks.
Yeah, absolutely right, Dr. Chandra. I think anyone would like to share their experiences about endometritis and pregnancy losses or IVF failures? Because chronic endometritis does cause changes in the immune profile at the endometrium, and immunohistochemistry studies for CD138 of the endometrium help us to detect these changes, and treatment of endometritis using antibiotics as well as immunomodulation using immunomodulatory agents combined help in these patients, which I think Dr. Sunita's patient was successful after treating endometritis and also immunomodulatory medications. Even active immunization in such cases using immunization therapy definitely helps. Anyone would like to share any?
Yes.
I want to share one case. She had again underwent IVF and IVF failure for 2 cycles. And in every cycle, whatever we gave, endometrium was thin and it was having fluid. So we wanted to go for ERA test to look for endometrial implantation window. And in that particular cycle, we gave her Bharglobe preconceptionally, empirically. And then we want to find out the implantation window. But the endometrium in that particular cycle was so good that we did IVF in the same cycle. Okay, let's forget about the ERA test. And she conceived and she delivered twins. So she said, okay, I recovered all my previous losses, and at times we plan something else and it goes something different. So in the same cycle, but the only thing which we did, it was preconceptually Bharglobe.
Yes.
Nothing else. So I don't know, it works so much. Because we all worked for everything, for chronic and for that GCF we gave, everything we gave for thin endometrium. But it didn't work for the last IVF. But in this cycle, when we planned ERA, so we could not go for ERA test. We did the transfer in the same cycle.
Great. And Dr. Mugdha, you want to share about your case?
Yeah, we had a case where she had 4 IVF failures. And they came to us through a family friend because the friend knew that we do LIT and immunological investigations. All other factors were ruled out, everything else. She had taken AKT, she had done laparoscopy, everything. So the couple underwent LIT, and after LIT, they wanted to try naturally after LIT. So we said okay. So the first response which the sonologist gave during the monitoring of the endometrium is that your endometrium never grew more than 6, even with I think 24 or 48. She was given a very high dose of Progainova. So he asked her, ki, what did you do differently that your endometrium has become so good? So that was the patient asked me. I said, no, we have only done lymphocyte. Must be some immunological cause. And in the third cycle of treatment, patient conceived naturally and delivered a healthy baby. Her son is now 1 year old.
So that's great. So I think many of
but
these
I think
problems.
thin endometrium, where all other factors are ruled out, there's no other cause. We must definitely consider the immunological cause for these couples.
Definitely.
So
And
great,
I have a question to Dr. Sunita. What was the treatment you gave for chronic endometritis, madam?
Yeah, so I gave a course of clindamycin plus metronidazole, and then after that I changed to doxycycline for 3 weeks. Actually, about I think it was 2 or 3 years back in the ISHRI, they were having this topic of full day workshop on recurrent implantation failure, where they said that the treatment of chronic endometritis is not of 5 days or 7 days. Doctor, you have to continue the treatment for weeks together. And that is how I got it, and I am giving these endometritis patient treatment. Yeah, for initially I give clindamycin and metronidazole, and then I switch over on doxycycline, and I continue it for 3 weeks, maybe 4 weeks, and then I stop.
Oh, great. I think this was an excellent discussion. I think a great variety of cases. I think different types of problems, miscarriages, implantation failures, endometriosis, late pregnancy losses, and excellent discussion. Lot of new learnings we had, and I think we had a great time. So I am thankful to all the doctors, our guests. I should not call panelists. They are all our guest doctors, for sharing their cases, sharing their experiences, so that which is going to help other doctors, other patients to achieve their dream of having their own baby. So with this, I close the session of case discussions, and I think I will hand over to Mr. Seshan for further proceedings.
Dr. Raut, there are many audience questions also that have come up. So
Right. Oh, sorry. Yes.
Chat box.
Right. I think we will. There are.
So can I take the last one, because I have to go? So
Okay.
should I take this Rupakshi's question? So Rupakshi, you've asked that you have done a IUI male factor. Now she's 6 weeks. And she's a known case of alopecia areata since childhood, not on any treatment, but hair fall on and off. Now on Defaston TDS, vaginal progesterone, 2-tablet BD, injection SCG 5,000 every 5th day. So Dr. Rupakshi, hi, hello, how are you? This patient, you have given too much of progesterone. So this is one rule now that one progesterone. So either you keep her on Defaston 10 milligram TDS, that is more than enough, or you keep her on vaginal progesterone 400 milligram BD. SCG has no role now. Her embryo is already secreting, her trophoblast is already secreting SCG, and as such there is no role of too many progesterones, so you have to stick on one progesterone. Because she is a case of IUI, and she is a known case of autoimmune disease also, in these patients Defaston is very good because it is a very good immunomodulator. So what I will do is I'll keep her on Defaston, folic acid and Bharglob in these patients, because IVIG is not available. It is very costly. You have to give her every week IV in the hospital.
Hello. I think
So
we are lost.
you need to give some thing as immunotherapy, and you can get. Hello, I think. Am I audible? Hello.
Yes, yes. Please go ahead. Please go ahead.
Yeah. So what I do is I'll give folic acid, Diffuston 10 milligram TDS, Bharglov every.
Hello.
Days. Then I'll
Hello?
go for her. Hello, I can hear you all.
Yeah.
So regarding LMWH and ecoaspirin, I'll start only when I see something there in uterine artery Dopplers. Otherwise, I will not start. So that is what I want to say, Dr. Rupakshi. I think I've answered your question.
Okay, I will take important questions. What is the dose of steroids in RPL given during early gestation by Dr. Manisha Gandewar? Dr. Mugdha?
Yeah, we give the dose of Vizolone. We give 10 milligrams 3 times a day from the time of the beta HCG being positive up to 3 months, 12 weeks of pregnancy. And then we gradually taper it down till in the next about 3 weeks we taper it down. So that is a dose of steroids which we give.
But isn't this a very high dose, 10 milligram 3 times a day?
Nothing. We have been using it for more than 20 years, but nothing happens.
I normally use 10 milligram once a day, and even in patients, IVF patients who have to continue 10 milligram for 3 months. I've never used such a high dose, but maybe I'll try not of new things I'm learning.
No, because it is said that in patients with repeated implantation failures, unexplained infertility, or even with repeated miscarriages, the endometrial steroids have been depleted. And once they conceive, which is where they are very important for implantation. So once they conceive, they require a dose of 30 milligrams of Vizolone. I hope I answered the question.
Yeah.
The next question is a patient, Dr. Banerjee, Reshmi Banerjee has patient of recurrent ectopic pregnancies treated with methotrexate, and she is refused salpingectomy or laparoscopy second time. Now she has come to her. How should we approach her? I think this problem, can anyone briefly tell what she should do?
Dr. Renu.
Recurrent ectopic pregnancies treated medically.
Right.
Yeah, treated with methotrexate.
Okay. So first we have to rule out the reason of why she was getting recurrent ectopic pregnancies. Since she is refusing laparoscopy, we do not know the tubal factor, whether it was some infection, chlamydial, or like Sunita said, in our side of the country, is very common. If give her a good course of antibiotics, Placentrex, rule out tuberculosis, and then go ahead with pregnancy. You can add immunomodulator, you can add Bharglov also, but you don't have much choice if she's refusing a laparoscopy.
Right. The next question is, which lab is doing NK cells and TNF alpha estimations?
TNF is being done by Laos Pathology. At our place, Laos is doing TNF.
Many labs do it. Metropolis lab, and from our side, even SRL lab is doing these tests.
So this doctor is from Lucknow who has asked the question. So if someone can be more specific.
I think Dr. Sunita.
Dr. Sunita from Lucknow.
Dr. Sunita will be able to tell. Yeah, she said Lal's Pathology.
What the major labs are doing it? Lal and Baxi, both of them are doing.
The question was by Dr. Babita Sinha. Okay. The next question is by Dr. Pallavi Kulkarni.
Yeah, Laos Pathology doing TNF. Getting it done regularly. Yeah.
Okay. The next question is by Dr. Pallavi Kulkarni. What is lead therapy or LIT or lymphocyte immunization therapy?
I think you people are the best to tell because you all are doing so many cases. How you go about it?
Dr. Mugdha, can you elaborate?
Okay. Lymphocyte
In brief,
immunization. Lymphocyte immunization therapy is an active immunization where we immunize the wife with allogenic lymphocytes to help in the formation, preferable formation of Treg cells. Like as I explained, that Treg cells are the major players, and the theory is that the body is rejecting the allogenic lymphocytes or paternal lymphocytes of a totally non-related donor. The lymphocyte antigens are from the paternal side. Or even if it's a donor embryo or a donor, it's rejecting allogenic lymphocytes or allogenic antigens. So basically, we use allogenic lymphocytes to sort of, it's like you can call it like a vaccine, where we inject it in the lymphocytes are separated and injected in the wife, and the couple is asked to wait for 4 to 6 weeks to either plan a natural pregnancy or IVF pregnancy and or a donor pregnancy or whatever they're going to do. We generally use husband's lymphocytes even if they are going in for donor embryo, donor oocyte or donor sperm, because husband is the safest. However, because he has been tested multiple times for infection profile, there have been instances where the husband has had an angiography or angioplasty at a very early age or a bypass. In those cases, we have used unrelated, we have related donors. We have a sister who has donated lymphocytes. We have a father-in-law who has donated lymphocytes. So in such cases, we take any allogenic lymphocytes, any donor will do, who has been tested, a HLA cross-match has been done with the patient and the infection profile has been done. But we generally prefer the husband because the husband is the safest. We've had even where a cousin has donated, a friend has donated.
Oh, okay. That's thank you, Dr. Mugdha. The next question we will take is, how can we manage a patient with previous 2 abortions with history of NIHF, that I think the non-immune non-immune hydrops fetalis in 1 abortion? So can anyone would like to elaborate?
What was the cause of the non-immune hydrops? Get to that.
So I think it will require more investigations from the immunological point of view, I feel, and only then we will be able to pinpoint, because otherwise it is difficult to say. Anyone would like to share? We'll go to next question. How is reproductive immunophenotype done? So that's a blood test, and it is done as the same labs, the Metropolis lab or Lal Path lab or SRL. They do these tests which involve the test related to the immunological cells, that is the natural killer cells and other lymphocytes. The next one is, should we refer our RPL patient to infertility units only? If we routine gynecs want to handle it, what is the way forward? RPL patients should go to infertility units only, or all routine gynecs can manage?
They can also manage.
They can also manage.
Yes, Dr. Renu?
Yes.
So I
They
think
can also manage.
They can also manage.
Can manage, yes.
Okay, we'll go to a few more questions. Should we do test for immune response? No, I think that question is not clear. It's a 1 minute. Should we do the immune test only once they are pregnant only, or even before pregnancy? What is the immune test for patients who have history of miscarriages? Should the test be done during pregnancy or before pregnancy?
Ideally, preconceptionally.
Ideally, yes.
And APLA has to be done 3 months after an abortion. a lot of people, will advise an APLA test just after miscarriage, but it should be done after 3 months. That is one thing which should be noticed.
I practice after 6 weeks because pregnancy itself is a state of thrombophilia. So I advise after 6 weeks or whenever the next period comes after abortion. On that day, I used to advise.
Okay. What are the
Dr.
options
Mohan,
with?
Dr. Mohan, I believe we have actually done elaborate justice to the why in immune modulation for this webinar. I request if we could pass the con to Mr. Saikat Banerjee from
Sure. I think this is this ends the questions also. So I think with this we end the question and answer sessions. I think.
Actually, Dr. Mohan, this is such an interesting subject that there will be a lot of questions will continue to come, and that is why we have planned this as a series. So some of the questions you can also carry forward to the next, webinars. So it will be a continuity. It will be a series because the name of the series is Why, When, and How. So why is being discussed. Now, when and how, obviously, it can be carried forward in the next webinars. But first of all, I would like to thank all of you, namely Dr. Mohan Raut, Dr. Mugdha Raut, Dr. Sunita Chandra, Dr. Madhu Gulati, Dr. Urvasi Shegal, and Dr. Renu Makwana, and I can say Dr. Sanjay Makwana also on the screen. So thank you to all of you for such a wonderful discussion, which is a subject which is not being discussed very often. That is reproductive immunology. And particularly the initiative what we as Bharat Serums and Vaccines have taken, that is Bridging Bharat initiative, we will definitely conclude it that when and how immunomodulation has to be done with all the panelists, new panelists also. There are 530 registration was there in this discussion. So obviously everybody has enjoyed, I believe, and there were some international viewers were also there from Philippines, Bahrain, Istanbul, Kenya, Germany, and Nigeria. So thank you all of you to come and join, and we will all expect you in the next webinar also, that is scheduled on 5th of August. Thank you. With this, I think we can conclude. Once again, thank you to all Dr. panelists, and of course, as Dr. Mohan Raut was telling, that not panelists, rather guest. Thank you to all of you.
Thank you. Thank you, Bharat Serum.
Thank you for the opportunity. Yes.
Opportunity
Thank you so much.
be, and we also learned a lot, especially we were staying, you're not staying in metros. I have also gained a lot from this session, and I'm really thankful to Bharat Serum, to Dr. Mohan Raut, and I've been in touch with him for the last 2-3 days, and it has been really very nice. Thank you so much.